All right, we're going to overview genetic diseases, and we're going to look at chromosomal problems, single gene defects, and then non-traditional inheritance, including mitochondrial and imprinting disorders. We're going to take a brief review of some common teratogens, and then we're going to look at syndromes overview by their main symptoms. So rather than memorizing each disease, how do they actually present, and how are they actually going to ask you a question about these diseases. All right, so the impact of genetic disorders in childhood disease, it is the single largest cause of mortality in the 0 to 5-year-old age group. 2 to 3% of all newborns have at least one major congenital anomaly. And if you look at both chromosome abnormalities and single gene disorders, at least 2% of all newborns will have some type of genetic condition. You should be familiar with the most common forms of genetic conditions and sort of the ballpark ranges of their frequencies. So Down syndrome, you can find a incidence of anywhere from about 1 in 660 to 1 in 800, but know that it's sort of in that ballpark. It is the most common genetic condition that we have. And then the listing of everything that is under about 1 in 3,500 with Duchenne's muscular dystrophy and going on down. So when should you think about a genetic disorder? Of course, if you talk to a geneticist, everything is genetic. And I just walked in at the last of the neurology lectures, and there were genetic things in there. So every lecture that you're going to get is going to have something genetic in it. I think everything is genetic. So you should just suspect it all the time. But it's true. Previous family history. So if you have a family that you know they have a genetic condition, you should be suspicious. If the parents are related, then you should suspect a genetic condition. If a woman has had multiple miscarriages and the magic number is actually 3, everybody's allowed to have 2, but once you've had your 3rd miscarriage, then we start to get worried. If you've had an in utero demise, if you have multiple birth defects or congenital anomalies, if you have developmental anomalies, so you have learning disabilities, mental retardation, which is now being supplanted by the term intellectual disability. So you may see that switch over as well. Neurologic symptoms, multi-organ dysfunction, anything that's on this list, you should be thinking about a genetic etiology. And like I said, every lecture you have will have something genetic thrown into it. So you should suspect genetic conditions when you see birth defects, and especially if you have at least 3 minor malformations or 1 major malformation. And the main difference between minor and major anomalies is that minor anomalies don't really affect you. They're interesting to look at. They're your clues for genetic conditions. So if you have 2-3 toes syndactyly, so your 2nd and 3rd toe are sort of stuck together. If your eyes are too far apart, tags in front of your ears, epicanthic folds, all of those are minor anomalies. They're not going to affect your health. They're not going to affect your livelihood. Major anomalies, however, are going to need some surgical repair. They're going to affect how you live your day-to-day life. So things like cleft lip and palate, congenital heart defects, brain anomalies, omphalocele, limb problems, all of those fall into that major category. So again, if you have at least 3 minors, or 1 major anomaly, you should think about a genetic cause. All right, so the different mechanisms that can produce disease, you can have problems with your chromosomes. You can have Mendelian disorders, which are your single gene disorders. Non-traditional inheritance, which is everything that's not Mendelian. And then multifactorial and polygenic disorders. So we're going to start with chromosome problems. So everybody remembers that DNA twists down, gets wrapped around its histones until you can finally take a picture of them as a chromosome. The P arm is the short arm or the petite arm. The other arm is the Q arm or long arm. Q just comes after P. It doesn't stand for anything. We're not that inventive. Okay, so here's a karyotype and a picture of a standard set of chromosomes. And you have 46 chromosomes in total, so your total count, you have 23 pairs. The first 22 pairs are the same between men and women, and those are called the autosomes. The last are the sex chromosomes. And if you have 2 X's, you're a girl, and if you have an X and a Y, you are a boy. I say that many times every week. Okay. How do you look at your chromosomes? The most common thing we do is look in the peripheral blood. And so we just take a blood sample, send it off to the lab. What we're looking at is the chromosomes in the white blood cells. So one of the common questions we get asked is, the baby's had a blood transfusion, can you get chromosomes? Yes, because you're looking at white blood cells, and usually with packed RBCs, you shouldn't have enough white blood cells to disrupt your ability to look at your white blood cells. Usually takes about 2 to 4 days to get a turnaround. If you have somebody who has cancer or a lot of birth defects and you think there's going to be an imminent demise, you can get a bone marrow sample, which will grow much more rapidly and get a quicker turnaround. You can also look at your amniotic fluid or CVS, chorionic villus, for prenatal testing. So aneuploidy is a word that we use that just implies that there's an abnormal chromosome count. So rather than a 46 number, there's now going to be not a 46. And these are associated with physical and developmental anomalies. Monosomy is a loss of a chromosome. So now you have a 45 count rather than a 46 count. The only disease that we have as humans as a monosomy is Turner syndrome, which is 45X. Many people may have learned it as 45XO. There is no O chromosome, so we've dropped that. It's just 45X. And then we have the common trisomies that you get tested on. So it's a gain of a chromosome. So now your count is 47. So Klinefelter's, which is 47XXY, and then down Edwards and Patau. So know both what is the trisomy and what is the eponym for that. So Down syndrome is a trisomy 21, Edwards is a trisomy 18, and Patau is a trisomy 13. For most of these, the risk is really increasing maternal age. And when you see somebody that has had a child with a chromosomal abnormality, we give them a 1% over their age-related risk until you reach age 35. Then just your age-related risk takes back over. All right, so now we're going to do Down syndrome. So this is the most common chromosome disorder in live births and occurs about 1 in 800 live births. Most people can pick out somebody with Down syndrome in the general population, has very characteristic facial features, short stature, short hands with a single transverse palmar crease. So about 70% of people with Down syndrome will have a single palmar crease, but realize that is none of these are pathognomonic. It's the whole picture that goes together. About 10% of people in the general population will have a single palmar crease, and 1% will have bilateral single palmar creases. So I was told there's 280 people now enrolled, so we should have 28 people with at least one single palmar crease and 2.8 people with bilateral single palmar creases in here. But realize when you look at, and everybody's got to look at their hands. Take a moment. Okay. But realize whenever you look at somebody and you think they may have Down syndrome, if they don't have a single palmar crease, that's okay. 70% will, which means 30% won't. It really just tells you how much you moved in utero. About half will have a congenital heart defect, 12% will have a duodenal atresia, less than 1% risk of leukemia, but still elevated over the general population risk, and the same with Hirschsprung's disease. Less than 1%, but elevated over the general population. And mental retardation that is variable, we usually say mild to moderate, so usually in the 40 to 60 range, but can range anywhere from 20 to 70. So the most common way that people have Down syndrome is to have a free trisomy 21, and that's in 95% of people. And you have a 47 count with that. So rather than having just one 21, then now you have 1, 2, 3 countable 21s. 4% are due to Robertsonian translocation. So one of the parents actually has a 45 count. They have a 21 and say a 14 hooked together. So they have movable living room furniture. They just put a sectional couch together. Whenever they have a child, however, when they give that 14 and 21 combines with the other parent's 21, and if they've given another 21 that was a free, the child actually has a 46 count, but still has an extra 21. Instead of this being free here, now it's just hooked on to a number 14 usually. So you still have three copies of that 21, but now it's just hooked to something else. And 1 to 3% will have some form of mosaicism. So that way there are different cell lines that are there. So there's a free trisomy 21 and a normal count, or a balanced translocation and a normal cell count. For the free trisomy 21, the risk will increase with maternal age. So here are pictures of people with Down syndrome. They have very characteristic facial features. The middle of the face is depressed, and it's called mid-face hypoplasia. They can have epicanthic folds. They have an increased gap between the first and second toe. Like I said, I did my training in Houston. I think every baby born near a beach has this finding, but we look for it in babies with Down syndrome. And again, a picture of a single palmar crease. Most of the babies will also look like they have a big tongue, but it's not necessarily a big tongue. It's just the hypotonia that's there, and that the tongue is sort of protruding out. And again, sort of that hypotonic face, very flat mid-face, a short, small head from front to back, and then the brush field spots. If you have a nice light-colored iris, you can see these pretty little spots around the outside of the iris. The ears are actually pretty classic too. This one has a nice squared off ear that's low set and small. Edwards syndrome is due to an extra chromosome 18 and occurs about 1 in 8,000 live births. It's usually fatal in the first year of life. Long-term survivors have profound mental retardation with IQs at around 20. They are born small and continue to have growth retardation and failure to thrive. Many will have low tone, but a lot will also have high tone. They also have severe heart defects. They can have a prominent occiput, low set ears, a short sternum, overlapping fingers, and rocker bottom feet. 95% are lost prior to delivery, so it's not necessary. Most don't make it to live birth. And again, is a problem of non-disjunction and meiosis, so increasing maternal age increases your risk. So these are little bitty babies when they are born. You can see the hand positioning with the overlapping fifth and second fingers. We often call that the trisomy salute. And then this is a rocker bottom foot. You cannot have an arch and a rocker bottom at the same time. And many times people will get very confused. They'll call you for multiple anomalies and say, well, I think the child has a club foot or a rocker bottom foot. Take a close look at the foot, because if it has an arch, it's not a rocker bottom. It really does have to look like a rocker. Trisomy 13 is Patau syndrome and is due to an extra chromosome 13. Is less common than 18, about 1 in 25,000 live births. Again, clinically severe and usually die within that first year, most within the first 3 months. Small eyes, cleft lip and palate, cutis aplasia on top of the head, born small, grow poorly, polydactyly, so in post-axial, so like a little nubbin on the pinky side, congenital heart defects, urogenital anomalies, and CNS abnormalities, including holoprosencephaly. So the clefting can be what I consider a normal clefting, unilateral or bilateral, but these kids are also prone to having median clefts, and if there's a median cleft, you have to worry about holoprosencephaly. Again, if you have a free trisomy 13, it's in advanced maternal age or non-disjunction that increases your risk. But about 20% of babies that are born with a trisomy 13 actually have an unbalanced translocation, and it's most commonly a translocation between 13 and 14. So one of the parents is carrying that translocation, has a 45 count, has a baby with a 46 count, but now has 3 copies of the 13. So you can see over here, this is a picture of the cutis aplasia. It just looks like the skin is eroded away. It didn't fill in appropriately. There's the baby with, this one is a bilateral cleft. It still has the little nubbin of material in the middle that makes the middle part of your philtrum. And clubbing of the feet, but they can also have the same rocker bottom feet that the 18s have and the same trisomy salute. If you see polydactyly, a median cleft, and cutis aplasia, That's going to be a trisomy 13. All right, so question number 1. Parents of a child who died shortly after birth with trisomy 13 and a 47XX positive 13 karyotype come to you for counseling about future pregnancies. Of the following, their risk for giving birth to another child who has a trisomy is closest to. Next slide. Okay, so there we go. Good job. So it's 1% added to the mom's age-related risk. So if you're a young mom, you get 1% added to your age. Once you're 35, then your age-related risk takes back over. All right, so those were your autosomal trisomies. Now we're going to go to sex chromosome abnormalities. About 1 in 500 newborns have an abnormality of either the X or the Y chromosome. 80% are XXX, XXY, or XYY. Turner syndrome is much less common, the 45X monosomy, and it occurs only about in 1 in 2,500 live births, and that's because most of those are lost prenatally. If you make it to birth, you do okay, but most of those are prenatal lethal. So we'll start with Turner syndrome. So 45X. Mosaicism is common. Again, there's a high rate of fetal loss. Clinical features include the nuchal webbing, puffy hands and feet, also known as pedal edema, congenital heart disease, in particular, coarctation of the aorta, short stature, infertility due to gonadal dysplasia. The only thing that is on this list that is consistent in all people with Turner syndrome is short stature. That's the only consistent thing you can say, is that they will all have short stature. There are only 3 ways to write the test question for Turner syndrome. You have a newborn baby with nuchal webbing, puffy hands and feet, and you do an echocardiogram and there's a cohort. What's the answer? Turner syndrome. You have a 2-year-old who comes in with short stature. She may or may not have a webbed neck. She may or may not have a heart defect. It's on the list of short stature etiologies. So you may have a toddler with just isolated short stature. The other way is that you have a teenager who hasn't started her periods, has not even started puberty, and so that delay in puberty and infertility also is Turner syndrome. So that's how they present to clinic. That's how they ask you the test questions. This is the only one that is not related to maternal age. And here's a karyotype, and it's just 45X. Many people think that the other one should have been an X, but it could have been an X or a Y. So the missing chromosome could have come from mom or dad. And again, this is not related to increasing maternal age. So here's a baby with the increase in the nuchal folds, a young lady that has the increase in the webbed neck, and then the puffiness on the top of the foot. Klinefelter syndrome is a trisomy with XXY. These men have tall stature, have small testes and infertility, which is a common way that they present. They grow up, don't know there's anything that's wrong until they're married and trying to have children and show up in infertility clinics. So that if you're doing OB-GYN, reproductive endocrinology, that's how they ask the question for Klinefelters. They can also have gynecomastia. Can have learning and behavioral problems, but that is not consistent between all people with Klinefelters. But if you look at their SIB groups, they tend to mature a little more slowly than their siblings do. You can also have more than 2 X chromosomes. So as much as women would like to believe that the more X's you have, the better you're going to be, actually that's not true. The more X's you have, the worse off you are. So if you have a 48 count, a 49 count, you're more likely to have mental retardation and a lot of other neurologic problems. So here's a karyotype for somebody with Klinefelter syndrome. And again, you can see the 2 X's that are here and then the Y chromosome. Common questions that we get in clinic is, does this make me a girl? No, you have a Y chromosome. The presence of the Y is what makes you male, not the presence of two X's. So women are women, not because we have two X's, but because we're missing a Y. Turner syndrome is female because it only has an X. There is no Y material that's there. So people with Klinefelter are male because they have a Y chromosome. All right, another question. 15-year-old comes to your office because she's never had a period. Her mother and sister both had menarche at age 13. She's had no chronic illnesses. She's active. She plays softball once a week. On physical exam, she's at the 5th percentile for height and weight. She has no hirsutism or acne. She has no breast bud development and Tanner stage 3 pubic hair development. So the most likely cause of her delayed menarche is congenital adrenal hyperplasia, Turner syndrome, anorexia, hypothyroidism, or 46XXY. Excellent. Okay, so this person has Turner syndrome. That's a very classic presentation. You know it's not CAH because she's not having any of the excess androgen problems. She's not having hirsutism. She's not having the increase in acne. She's not having the signs of virilization. Klinefelter would be male and not female. Anorexia would have low weight with a normal height, and she should have some breast development. And primary hypothyroidism wouldn't explain the lack of breast development. Okay, so those are all the big things that we've been able to see for a long time. Now we're going to move into microdeletion syndromes. So rather than missing a whole chromosome, now we're going to look at missing teeny pieces of chromosomes that you may or may not be able to see on a regular karyotype. These are called microdeletion syndromes or contiguous gene syndromes. So they're small chromosomal deletions. A couple of them that we'll talk about you can see cytogenetically, but you have to be a really good cytogeneticist to see them, but you should be able to pick them up. We now can have better technology that you can see even smaller than just your karyotype. They'll affect several neighboring genes, hence the name continuous gene syndrome, and they produce a composite phenotype. We use FISH, or fluorescent in situ hybridization, in order to pick these up. Use a labeled probe to detect a specific area. If it's normal, you should have two lights lighting up. If it's abnormal and something's missing, you should only have one probe lighting up. Whenever you go fishing, you should know what you're fishing for. So if you just send a lab test that says fish, the lab's going to come back and go, for what? You have to write down something. All right, so for 22q microdeletion syndrome, this is what the probes look like. Because we're geneticists and we know that there are people with red-green color blindness, we often do things in red and green, so that way everybody's always confused. Major national meetings of geneticists, they will do everything in red and green. Makes no sense to me. Anyway, so here we go. So here's your reporter probe that's in green right here. That's your 22, and there's another 22 here. And you can see on this 22 there's a red probe, but on this one there isn't a red probe. So you're missing something. Does that make sense to everybody? Okay. And if it doesn't, don't worry, because it'll come back on your lab report that says it's missing. They won't make you read this part of it. All right, 22q microdeletion syndrome, we're actually moving more to calling it 22q deletion syndrome. For a while we tried catch-22. That didn't really catch on, but it's a nice mnemonic for learning. So the catch is cardiac defect, usually conotruncal defects, abnormal facial features, T-cell deficits, clefting, and hypocalcemia, so low calcium. Variably known as DiGeorge, Velocardiofacial syndrome, and Spritzen syndromes. So you'll see all of those terms associated with the 22q. Has a variable clinical presentation even within a family. So you'll see some people who have heart defects, some who don't, some who have learning difficulties, some who have mental retardation, some who have no problems at all. They're prone to having behavior and psychiatric problems like bipolar and schizophrenia. Cleft palate rather than a cleft lip and palate. thymus and parathyroid hypoplasia, and T-cell problems. The reason why we have names like DeGeorge, Velocardiofacial, and Spritzen is because before we knew what caused it, depending on how you presented, you got one name. So if you were very severe, you got DeGeorge. If you were more mild, you got Velocardiofacial syndrome or Spritzen syndrome. Turns out they're all the same. Everybody has the exact same deletion. So if you have a patient that has a congenital heart defect and a learning problem, think about 22q. Congenital heart and a cleft palate, think about 22q. The characteristic facial feature is a tubular or boxy nose. So if everybody turns to their partner and looks at their nose, your nose should approximate a triangle. Some of us are more of a straight triangle rather than isosceles. Okay, but people with 22q, you can see the broadness across the nasal bridge, and it becomes much more of a rectangle shape. And that feature gets more prominent as people get older. It's hard to pick up in newborns. Okay, so we'll move on to 5p minus syndrome, also known as cri du chat, which is the only French I know, which stands for cry of the cat. So these are the babies that whenever they cry, they mew. And it's a deletion on the short arm of chromosome 5, or 5p. And the critical region is 5p15, and that's also what gives you that cat mewing sound. I think that these children look dysmorphic, but they don't have a particular flavor to them, so you just sort of look at them and go, they're dysmorphic. They're not consistent like a person with Down syndrome or 22q, where you look at them and you can really pick out what's going on. Most of the time, this is a sporadic condition, but 10 to 15% are due to parental translocation. So again, inheriting a translocated chromosome from a balanced parent now gives you an unbalanced child with a 46 count. Clinical features include a small head, high palate, eyes that are too far apart, again, epicanthic folds like you see in Down syndrome, and a low, broad nose. So between the eyes and across here is much lower than the average person. The other common autosomal deletion syndrome is 4p minus, which is Wolff-Hirschhorn syndrome. These children have severe growth retardation. They also have mental retardation, small heads, and their characteristic facial features is this Greek helmet face. And so everybody remembers this Greek helmet where you come up and then down and over the nose. And so they have a very prominent glabella, which is this part right in the middle of your face, and it sticks out, and you can always see this Greek helmet facial pattern with them. They have problems with closure, so they can have cleft lip and palate, colobomas in the eye, and cardiac septal defects. I always like the syndromes that are acronyms because it tells you what it is that you are supposed to be looking for. So WAGR, W-A-G-R, Wilms tumor, Aniridia, GU anomalies, and mental retardation. Can be due to somatic mutations, but can also be due to a contiguous gene deletion on 11p13, where the Wilms tumor 1 gene is. So you can either have mutations in the gene, or you can just delete that whole area. And again, the features are Wilms tumor, Aniridia, GU anomalies, most usually hypospadias in males, and mental retardation. All right, so those are the chromosome areas. Now we're going to move to single gene disorders. Everybody remembers the P-plants and how to do Punnett squares. If you don't, go back and play with your Punnett squares. You'll have at least a couple of questions where they will ask you recurrence risks. So types of Mendelian inheritance: autosomal dominant, autosomal recessive, and then X-linked conditions, both recessive and dominant. So we'll start with dominant. Presence of one mutant allele is sufficient to cause disease. So remember, for each trait that you have, for each gene, you have two copies, one from mom, one from dad. So for a dominant condition, only one of those has to be mutated. Both sexes are affected equally because it's on the autosomes. Affects multiple generations. Once you have a disease, then you have a 50-50 chance of passing that to your child. It won't skip a generation, because if you've opted out of your family plan, you've opted out. Then you can't pass it on. There's male-to-male transmission. And here is a pedigree, and you can see there's somebody in each generation who is affected. Once you are not affected, you've opted out of the family plan, there's nobody else here that is affected. So when that person goes to have a child, the big A now is the dominant condition in the mutation. Remember your Punnett square? They have a 50-50 chance of passing that on. Okay, so common autosomal dominant syndromes. Marfan syndrome occurs in about 1 in 10,000 people. 25% are due to a new mutation, which means 75% will have a family history and somebody else in their family will have Marfan's. It's due to a mutation in the FBN1 gene or fibrillin gene. Most are family-specific mutations. There's no common one, so there's not a specific mutation that we can look for over and over again. The protein is fibrillin, and so it makes a defective fibrillin protein. The phenocopy for Marfan's is homocystinuria. Homocystinuria is a recessive condition, makes you look like you have Marfan's. You're tall, you're lanky. You can have dislocated lenses just like you can in Marfan's, but you often will have psychiatric and learning issues as well. There are clinical diagnostic guidelines known as the Ghent criteria to help diagnose people with Marfan's. So usually what we think of with Marfan's, these are tall, skinny, lanky people. We pick them up on sports physicals. They're great at basketball and volleyball. They've got this great arm span. Scoliosis, pectus deformities, and long fingers or arachnodactyly. However, the major things that you really want to look for are dislocated lenses and aortic dilatation and dissection. That's the whole reason why you want to diagnose somebody with Marfan's, is to keep them from dying. Not common in this group is learning disabilities. They have them at the same rate as the general population. So here's somebody with the tall body, lanky body habitus, and the increased arm span. You can also start to see she's developing a little bit of scoliosis. A pectus excavatum, the carinatum is the one that pushes out. Wrist and thumb signs. So a thumb sign, you have to put your thumb in and fold over. If you're pushing on it, you're cheating. Okay, just in and fold over. Has to go past your knuckle. Okay, so some people can get it to come out a little bit, and you'll see people try really hard in my clinic, and I don't know why, because you don't want to have this, but they'll sit there and go, but I think I can do it. No, don't do that. So just put it in, lap over. Has to go past the knuckle. Same thing with the wrist sign. Thumb to pinky, not to the first one, to your pinky, has to go past the knuckle. So some people will be able to overlap just onto the nail. It has to go past the knuckle. And that's getting at those long fingers, arachnodactyly. Okay, so the Ghent criteria have been changed. And I don't know when in taking this test that change is going to hit. Okay? So the old way of doing this, you needed, if you had no family history, you needed major criteria in 2 different organ systems and involvement of a 3rd organ system. If you have positive family history, you only need 1 major criteria in 1 organ system and involvement of a 2nd. In 2010, there's a revised Ghent criteria, and if you go to marfan.org, their support group, you can actually get on, and they'll take you through the whole thing, and you can enter it in, and they'll give you all sorts of scores, and it's a lot of fun. They moved to doing more of a point system, which is nice. So now the major criteria, ectopia lentis, aortic dilatation or dissection, and family history. If you have any 2 on that list, you have Marfan's. Done. Don't even have to do an arm span. Okay? So you need 2 or more of those. If you don't have 2 or more, you just have 1 major, now you have to go to a point scoring system for all your systemic features, which includes your wrist and thumb signs, includes skeletal features like pectus, scoliosis, eye problems like myopia, pneumothorax, but now they're all given a point system. So in the old one, it just said wrist and thumb signs. Now you get 3 points if you can do wrist and thumb, but you only get 1 point if you can do one or the other. So it gives you a much more, I think, precise way of being able to really figure out what's going on with the person. The other way of doing this is if you do testing and you have a known mutation in the fibrillin gene that has been associated with Marfan's, then you can make the diagnosis as well. Again, there is an AAP health supervision guideline for people with Marfan's. All right, question number 3. Late summer and time for the yearly sports physical exams. Must be today. Last patient of the day is a 16-year-old varsity volleyball player. Girl's height is 71 inches, weight is 125 pounds, which I wish I were, and blood pressure is 115/74. On exam, you find scoliosis and 3/6 holosystolic murmur at the cardiac apex with radiation to the left axilla. Most likely diagnosis for this patient is Ehlers-Danlos, infective endocarditis, Marfan's, rheumatic heart disease, or Williams syndrome. Good job. So this is the clinical way, the best way in a clinical vignette that somebody actually comes to recognition is in a sports physical. I'm happy to see people all day long to rule out Marfan syndrome to find the one person that you'll save from having an aortic dissection early in life and dropping dead on the volleyball court or wherever. So that tall, lanky body habitus, the holosystolic murmur that may be due to mitral valve, the scoliosis, all of those things start to play into thinking about Marfan's. Again, if you refer them to me, then we'll do the Ghent criteria, but they really should stop at the cardiologist first because I can't complete the Ghent criteria unless they've seen the ophthalmologist and the cardiologist. We'll come back and talk about Ehlers-Danlos in a little bit, but those people usually have more stretchy skin, easy bruising, and have joint hypermobility. Williams syndrome is a chromosomal deletion, which gives you mental retardation, short stature. So again, not in keeping with this. And then no other information that would lead you down infective carditis or rheumatic fever. Okay, other autosomal dominant conditions, allegeals. Autosomal dominant, JAG1 and Notch2 genes. Clinical features, paucity of bile ducts. The characteristic cardiac feature is peripheral pulmonic stenosis. Eye anomalies, characteristic posterior embryotoxin, also known as prominent Schwalbe's line. Butterfly vertebrae. And then the facial features are prominent forehead, deep set eyes, eyes that are too far apart, hypertelorism, a pointed chin, and a bulbous nose. And so that tip on the nose looks more like a little ball than being smoothed out. Achondroplasia. I've never really seen them ask about any other dwarfing condition besides achondroplasia. It is the most common dwarfing condition, so therefore you have to have short stature. Everybody has absolute macrocephaly. It's not just big for their bodies, it is off the scale. It's 100% penetrant, which means that everybody who has a mutation shows symptoms of the disease. It's due to a mutation in fibroblast growth factor receptor number 3. So the men don't get out of this either. So women have an increased risk of having chromosome abnormalities as we get older. As men get older, they have a higher risk of having new onset mutations in dominant genes. So there is a paternal age effect. So if you look at spontaneous new mutations in a family, often you'll find an older father. And the new mutation rate for achondroplasia is about 80%. So remember, for Marfan's, it was about 25%. For achondroplasia, it's about 80%. And again, there is an AAP guideline for health maintenance for these kids. So for most autosomal dominant conditions, if you're a homozygous affected, you're much more severe than the heterozygotes. And the classic example is two people with achondroplasia having a child. If the child is a double dominant, They've inherited the mutated gene from both parents. That is a lethal condition. The chest is too small, the lungs don't develop, and they pass away shortly after birth. Another autosomal dominant syndrome is CHARGE. It's generally thought to be sporadic, a new mutation in the family, and it's a mutation in the CHD7 gene. Again, nice mnemonic. C, colobomas and CNS disease, heart defects, choanal atresia, retardation of growth and or mental capacities, GU anomalies, and then ear anomalies and or deafness. So they have kind of a characteristic ear and then may also be deaf. If you do a temporal bone CT, you may find a Mondini defect, and then that makes you think about CHARGE. Here you can see the coloboma, and it's not the classic keyhole, it just looks like sort of an oval coming down to the bottom. Osteogenesis imperfecta is another dominant condition. It's a disorder of type 1 collagen due to mutations in COL1A1 or 1A2. There are 4 main types of OI that range from mild to lethal. The most mild one is type 1, the lethal one is type 2. 3 and 4 are somewhere in between. So the clinical feature, osteopenia, multiple fractures, short stature, scleral hue changes. We get lots of referrals for babies with blue sclera and no fractures, so blue sclera can be a normal variant in infancy. Dental abnormalities and hearing loss. Usually the way that we encounter these people is in the context of, is this OI or non-accidental trauma? So you should also be familiar with what types of fractures are pathognomonic for NAT, and also that retinal hemorrhages don't go along with OI. All right, so when you have a sporadic case, neither parent is affected. We know that new mutations occur, and they occur with varying frequency, and it depends on the disorder, the reproductive fitness, and the gene size. So the more severe the disorder, the more likely it is going to be a new mutation. So something like lethal OI is going to be always a new mutation because you have to have a parent. Something like Marfan's, you can live to reproduce before anything bad actually happens to you, is more likely going to be inherited and have a lower new mutation rate. So once you have the condition, you have a 50-50 chance of passing it on, but we tell the parents that they actually have a pretty low risk, a less than 1% chance of passing that on or having it happen again in their family, having lightning strike twice. And then there are families who defy our odds and prove us wrong. And so you'll find people that have had more than one child with the same dominant condition. So here's a mom with 2 different spouses that have had 3 children with lethal OI, and here's a set of parents who have 2 children with achondroplasia. None of the parents are affected. And in this case, we think about germline or gonadal mosaicism. So the parent actually is harboring a mutation, but only in the germline cells, so either in the egg or the sperm. So the parent looks fine, but the egg or sperm are actually carrying this mutation. So they actually have a higher recurrence risk than what we would think for just a straight-up sporadic condition. And the recurrence risk depends on how high the proportion of the mutant alleles are in the gametes. All right, so now we're going to move to recessive conditions. So rather than just one being mutated, now you have to have both being mutated to produce a disease. Males and females are affected equally. Low risk to offspring if you are affected. So if you were affected with the disease that was dominant, you'd have a 50-50 chance of passing that on. If you have a recessive condition, you're actually going to have a very low risk of having a child with your same condition. However, your parents who have a child with a recessive condition will have a 1 in 4, 25% chance of having another affected child. And remembering statistics, just because you've had one child with a condition is not your 1 out of 4. You're not guaranteed that the next 3 won't. Okay? People have magical mathematical thinking. You have to keep reiterating to them each pregnancy is that same 1 in 4 chance. This is the other trick question. If you have a sibling with a recessive condition and you are not affected, you now have a 2 out of 3 chance of being a carrier. And hopefully when we do the Punnett square, that'll make a little more sense. Okay, so here's a pedigree. The only people who are affected are in this SIB ship, and it's not occurring anywhere else. Here are the two parents who are both carriers. The big A is normal, the little a is the mutated copy. And so 1 out of 4 chances that you are affected. If you are not affected, then this doesn't count anymore. And now you only have 1, 2, 3 boxes to count from. So you have 2 out of 3 chances to be a carrier. Other things with recessive conditions is consanguinity or interrelatedness. So here we have that denoted by double bars, and these people are first cousins. And you're more likely to see this with very rare disorders, geographically isolated populations, and then communities that are isolated because of their ethnic or religious beliefs that intermarriage is the standard and norm. Common recessive conditions, cystic fibrosis, about 1 in 2,500 people of Northern European extraction. Due to mutations in CFTR, there's over 1,000 known mutations. However, the most common mutation is the delta F508 mutation. Most states are now screening on newborn screen for CF, but not all. So depending where you came from, and we'll come back to newborn screening at the very end, know what's going on in your state. If a baby isn't born in your state, you can always pick up the phone and call the other state where the baby was born, and also know that things change over time. So just because CF is now being tested for doesn't mean that 5 years ago in whatever state that the child was actually tested. It's a defect in the sodium chloride transporter and affects multiple systems, most commonly the pulmonary, pancreatic, and reproductive systems. Other common recessive conditions, the hemoglobinopathies. Structural defects are sickle cell anemia, and then production defects are the alpha and beta thalassemias. More common in populations that had endemic malaria. And the treatment is often with transfusions, problems with iron overload as a complication, and you have an increased RBC turnover. All right, so X-linked inheritance. In this case, the males are going to be severely affected. And it's usually passed through a healthy carrier female that have a 50-50 risk of transmitting the disease to their sons. There is no male-to-male transmission. If you have a male who is affected, all of their daughters are obligate carriers. So here's a traditional pedigree where you have the males filled in as being affected and the girls with the little dots as being the carriers. If you have a carrier mother, you have the pink X that's going down, you have a carrier daughter and an affected son. Be careful when they ask you about recurrence risks with X-linked diseases, because they will ask you what percentage of their children will be affected. 25% of the children will be affected. How many of the sons? Half. How many daughters will be carriers? If the dad is the transmitting, but if it's the mom, in this case, then one's going to be carrier, the other one's not, so 50-50. So in the scenario for X-linked conditions, they can ask the question based on all children, boys, or girls. So underline, do whatever you need to do to know what it is, what question are they actually asking you, because you may think they're asking you one thing and move on. Okay, so the Lyon Hypothesis gets to the fact that all women are mosaic for everything that's on our X chromosomes. So men only have one X chromosome, so the women have to turn off one X chromosome in every cell, so that way we have a dosage compensation. The second X, the one that's been condensed and inactivated, is known as a bar body. And the inactivation occurs early in development and is completed by about the end of the first week of life. It's random, but once it's made, the decision is permanent. So, statistically speaking, it should be a 50-50 split. But you can see women that are 60-40, 70-30, 90-10. So if you inactivated the wrong chromosome and you're a carrier for an X-linked condition, you may end up looking like you're a woman with an X-linked condition if you inappropriately inactivated your X chromosome. All right, so everybody know about cat color, coat color? Okay, so this is a calico cat. The coat color is encoded on the X chromosome. So is this a boy or a girl cat? Has to be a girl cat. If you turned the cat over and found out it was a boy cat, what's its chromosomes? Has to be XXY, because it's got a Y to be a boy and it's got 2 X's to be calico. You guys are good. That won't come up on your test, but it's fun at parties. Okay, so all right, so again, you're doing a dosage compensation, so that way the men have 1 X, the women have 2. You want us to always be working off of 1. And it gives you that variability of expression in women carriers. And women are mosaics with respect to all of their X-linked genes. So common X-linked conditions, you just heard about Duchenne's. Progressive muscular dystrophy, the onset is in early childhood. You become non-ambulatory by your teens. About 1/3 have cognitive delays, and they're at risk for cardiomyopathy. So due to mutations in the dystrophin gene, there is a high new mutation rate, and it appears to arise during spermatogenesis in the grandfather. So there's a mutation in the gene on the X chromosome. He gives that to his daughter, who is unaffected, who then has a son with Duchenne's. And there's also germline mosaicism that has been described with Duchenne's as well. Again, the classic pictures of Duchenne's, and you just reviewed this. This is the calf pseudohypertrophy, and you can begin to see the sway back and the loss of that muscle strength in trying to stay upright. Incontinentia pigmenti, also known as IP, is an X-linked dominant condition that mostly affects females, and the male fetuses tend to miscarry if they're affected with that. 40 to 60% have nail dysplasia. About 1/3 will have ocular changes, including cataracts and microphthalmia. 65 to 90% will have teeth and jaw problems, including delayed eruption of teeth, hypodontia, microdontia, and abnormally shaped teeth, such as round or conical or peg-shaped, a small jaw, micrognathia, or prognathia, where it's coming out more than it should be. And 10 to 40% will have CNS changes. So here's the characteristic swirly lesion along the lines of Blaschko. And usually they come up as vesicles first, scab over, and then leave behind this hyperpigmentation. And then having the tooth problems, these peg-like shaped teeth. G6PD is a favorite on exams. It's X-linked recessive. For the women to have symptoms, you have to have both copies with mutations in them. Confers the resistance to malaria again. And there's hemolytic anemia when you're exposed to oxidative drugs, including chloramphenicol, anti-malaria drugs, and the ever-favorite fava beans. If there's a fava bean question, you're looking at a G6PD question. Rett syndrome is an X-linked dominant condition. We have found a few males, but they're much more severely affected even than the girls, so we just still think of it as being an X-linked dominant due to mutations in MECP2. These little girls look normal at birth and develop normally up until a point to which they stagnate, lose skills, and then sort of stabilize. They have acquired microcephaly, so again at birth they have normal birth parameters, but their head grows much more slowly than the rest of them, so over time they become microcephalic. They have a very characteristic hand wringing that they do. They just sit and play with their hands. So if you ever see a little mentally retarded girl and she just keeps playing with her hands, very likely she has Rett's. Seizures, breath holding, and air swallowing in autistic features. Alport syndrome, again, women have a milder disease in this X-linked form. It's a disorder of the basal membrane collagen, called 4A5. 3 major findings include kidney failure. It's the second most common cause of kidney failure, deafness, and an abnormal eye exam. There are also dominant and recessive forms of Alports. Aicardi syndrome is an X-linked dominant disorder with lethality in males. We don't know the gene, but it does have a triad of features, including agenesis of the corpus callosum, chorioretinal lacunae, and infantile spasms. They can also have microcephaly, axial hypotonia, and moderate to severe mental retardation. All right, question number 4. 10-year-old girl presents for evaluation of multiple cafe au lait spots, nodules under the skin, and severe scoliosis. Family history is notable for a father who has scoliosis and similar spots, a paternal aunt who has had an optic glioma and bone problems, and a paternal grandfather who has had joint dislocations and now has a large mass on his back along with spots. Based on the family history, the most likely pattern of inheritance of this condition is good. So this is a dominant condition. And you've got male-to-male transmission. You've got somebody affected in every generation. Another question. 1-week-old female presents for her first newborn evaluation. She's been discharged apparently well and thriving at 48 hours. She had been noted to have blisters and linear streaks without any erythema. The blisters are starting to scab, and her mother is concerned that it may be warts. When talking with the mother, you notice that she has some peg-shaped teeth. The most likely diagnosis is bullous impetigo, congenital varicella, HSV, incontinentia pigmenti, or recessive dystrophic epidermolysis bullosa. Good. So answer is incontinentia pigmenti, and again, those vesicles that are coming up and then starting to scab over is what is very consistent with IP. The absence of erythema in a healthy appearing child makes HSV unlikely. Bullous impetigo should have bulla, not vesicles. And then hemorrhagic bulla are characteristic for epidermolysis bullosa. All right, non-Mendelian inheritance, things that don't look like single gene defects. So they don't follow dominant recessive or X-linked patterns. So we'll cover genomic imprinting and uniparental disomy, mitochondrial inheritance, and trinucleotide repeats. So imprinting defects is the way that our system turns on and off certain genes. So it should be that everything is created equal. You get one copy of a gene from mom and one copy of a gene from dad. That's not entirely true for all genes. There are some that the only active copy comes from mom, or the only active copy comes from dad. And the way that we turn things on and off are by these imprinting mechanisms. So in this particular scenario, Michael is affected with a condition, and when it's on the maternal side, it's when it's active, but when it's on the dad side, it doesn't matter because it's already inactive. It's already been turned off. So he passes this to both of his kids, and now the paternal side is inactive. So neither of his kids have the disease, but they're both harboring that mutation. Again, when the boy has it, it's still inactive because it's on the inactive copy. But when mom goes to give it away, hers is the one that now is turned on, and it has a mutation in it. So now you're going to see it again. Okay, so it looks funny. It looks like it's skipping generations, and it can work through male or for female depending on what the genes are. So the absence of gene from one parent results in abnormal development because now essentially you're only working on one copy. So the classic characteristics or classic syndromes for this are Prader-Willi and Angelman syndromes. And they're both due to deletions of chromosome 15 in the region of 15q11 to q13. And you have a different phenotype depending on the parent of origin of the deletion. If you have a loss of your paternal genes, you have Prader-Willi syndrome. If you have a loss of your maternal genes, you have Angelman syndrome. So Angelman syndrome gives you severe mental retardation and microcephaly. You have an ataxic gait with jerky arm movements, and so the old term for this was the happy puppet syndrome. Seizures and EEG abnormalities. Bouts of inappropriate laughter, again, the happy puppet. And have a small head, brachycephalic, short front to back, maxillary hypoplasia, deep-set eyes, a large mouth. Over time, the jaw becomes relatively larger with prognathism. Blonde hair and blue eyes in the Caucasian patients, but generally much lighter than whatever your background ethnic group is. Prader-Willi syndrome gives you hypotonia and failure to thrive as an infant. And then you have rapid weight gain between ages 2 to 4 to clinical obesity. Small hands and feet, hypogonadism, short stature, and mild to moderate learning problems. People with Angelman have severe to profound mental retardation. Prader-Willi, mild to moderate. Beckwith-Wiedemann is also can be due to imprinting disorders. This gives you, it's an overgrowth syndrome, so you're big when you're born. So macrosomia, or large size. Macroglossia, a big tongue, and you can see here, as opposed to the kids with Down syndrome, this person is not hypotonic, but their tongue is too big for their mouth. They can have earlobe creases or pits, hemihypertrophy, omphalocele. They have an increased risk for embryonal tumors, including Wilms tumor and hepatoblastoma. So there is a, we do renal ultrasounds and liver ultrasounds up until age 8 every 3 months. Because they're big babies when they're born, they're at risk for hypoglycemia. And again, they're due to imprinting disorders, but can also be due to specific mutations and inherited as an autosomal dominant. Trinucleotide repeats are a series of 3 base pairs in the DNA or RNA coding for a specific amino acid. And they're normally stably transmitted. So we all have these repeats in certain genes, and they should be a certain number. But they can begin to expand, because where those keep repeating, you can slip and slide when you go to reproduce and make your gametes. The characteristics of trinucleotide repeats is that the size of the repeats correlates with the severity and age of onset. So the bigger the repeat, the earlier the onset and the more severe the symptoms. The size is influenced by the sex of the parent that's transmitting the trinucleotide repeat. So things like Fragile X in myotonic dystrophy increase through the maternal cell line. Things like Huntington's chorea increases through the paternal cell line. Anticipation is this phenomenon that you watch within a pedigree, that things keep happening earlier and getting more severe with each generation. So Fragile X syndrome is the most common inherited form of mental retardation. So those are trick questions. The most common mental retardation syndrome is Down syndrome, and it's a chromosomal problem. Most are due to non-disjunction and not inherited. So if it asks you about the most common inherited form, you're at Fragile X. What's the most common environmental teratogen? Alcohol. What's the most common virus? CMV. Good job. So Fragile X accounts for about 6% of males with mental retardation, and about 30% of the carrier moms will have findings as well. They will have mental retardation plus or minus autistic features, large ears that are consistent throughout their lifespan, generalized overgrowth with large, tall stature, large head, hands, and feet. The macroorchidism is only post-puberty. So if you're looking at a 4-year-old, that's not going to be a reliable sign. But if you're looking at a 15-year-old, then that's going to be a reliable sign. It's due to a CGG repeat and the FMR1 gene, and again, it's X-linked. All right, multifactorial inheritance. This is the interaction between your genes and your environment. So that genetic background that you have that predisposes us to having common conditions. And it underlies most common conditions, whether or not we're talking about hypertension and diabetes, or cleft lip and palate, neural tube defects, heart defects, pyloric stenosis, congenital hip dislocations. And again, in adults, diabetes, hypertension, psychiatric disorders, we all have this genetic background we bring with us, and what environment do we interact with. When you see something that's multifactorial, the risk that we get from just population studies is about a 2 to 5% risk of having it happen again in future pregnancies. And again, this threshold model that you have a certain liability. If you're not in the right environment, you'll never get that disease. But if you're in a very strong environment, then you'll get it. But if you've got more genetic input, then your environment has to be a lot less to get you to trip over that threshold. So differences between cleft lip and palate and isolated cleft palate. So isolated cleft palate is distinct from cleft lip and palate. And some syndromes may have associated cleft lip plus or minus the cleft palate, can be recessive, dominant, can be chromosomal disorders. So you can find them in a variety of conditions, but you can also find isolated cleft lip and palate, isolated cleft palate, not associated with other things. So cleft lip for multifactorial inheritance is about a 4 to 9% recurrence risk. Bilateral is going to give you a higher recurrence risk than unilateral. So the more severe something is, that you assume there's more genetic liability for it. A male infant is born with bilateral cleft lip. Findings on the remainder of the physical exam are normal, as is the family history. You inform the parents that this is apparently an isolated birth defect. During counseling with the family about their risk for having another similarly affected child, the statement that you are most likely to include is, give you a moment to read all of them. And go. And everybody picked B. And the correct answer is B. So bilateral cleft lip with and without cleft palate is a multifactorial trait that has a 6% risk of recurrence. And again, if you're seeing somebody with a major birth defect, you're wanting to look for other things that would tell you about a syndrome. But the vignette was telling you you didn't find anything else. So if you had a unilateral, it's probably more around 4%. Bilateral, you're going to skew that upwards a little bit to 6%. So just keeping in mind that most multifactorial, you can ballpark to 2 to 5%. There are some that are have higher recurrence risks, like hypospadias, which may be upwards of 10%. But those are all stated in a book somewhere. So if you have to guess, 2 to 5% is your first baseline. And if you're bilateral or more severe, tack towards the higher end. All right, in utero exposures. So potential teratogens include infectious agents, physical agents, drugs and chemicals, and maternal factors. So factors that affect how much of a teratogen something is the dose, the timing of exposure, your susceptibility, your own genetic background and how susceptible you are. Other environmental factors, are you getting one hit with an exposure or multiple hits? Most common teratogen worldwide is alcohol. And the physical features for fetal alcohol syndrome include a small head, microcephaly, a smooth philtrum, so this little part right here underneath your nose, it's supposed to have a nice cute little ridge to it. If it's flat, that makes us worried. Short palpebral fissures, so your eye opening is smaller than it should be. Growth deficiencies, a number of different types of internal anomalies and birth defects, and again, developmental delays and a lot of behavioral problems. Can have milder features that are known as fetal alcohol effects. The problem is you have to have a known alcohol exposure. Not many women will tell you how much they've been drinking. So a lot of times it's a guess, and we see a lot of kids that are in foster care, and it is a guess, and then you also have polydrug use as well that just sort of mucks up the whole system. But the classic features, is that smooth philtrum, that thin upper lip, small palpebral fissures, learning, and those behavioral problems. They just struggle with making good decisions. If you take Dilantin during pregnancy, then you can also end up with birth defects. 10 to 15% will have a problem on the developing fetus. Again, a small head, small growth, heart defects, cleft lip, short upturned nose, and a depressed nasal bridge. So you can see here that this little bridge across here is really low. Nail hypoplasia and hypoplasia of the distal phalanges is one of the characteristic findings. Fetal varicella syndrome, usually less than 20 weeks gestation exposure carries the highest risk, and it can give you limb hypoplasia, eye damage, developmental delay, and really bad scarring. Moms can also have diseases that affect their children, and so the two most common things that we worry about are maternal PKU, but if the mom does not control her phenylalanine, it is a teratogen to the fetus, and the placenta concentrates phenylalanine at 2.5, the level of the mom. So whatever mom's level is, the baby's seeing 2.5 times that level. And so that affects the baby's brain development, overall growth, and they often have a lot of the same physical effects that the kids with fetal alcohol syndrome do. Maternal diabetes gives you an increased risk of neural tube defects, renal anomalies, and heart defects in 10%. Okay, that's halfway through. I gotta talk faster now. Okay, so now we're gonna move from this is how the disease and how it presents to here are ways that things present. What is the disease? All right, failure to thrive and poor growth. Kids come in all the time with that. Remember that certain kids with certain diseases, they actually have their own growth charts for them. So before you call them failure to thrive, make sure you plotted them on the right growth curve. Kids with Down syndrome have their own growth curve. So make sure they're growing appropriately for their disease. All right, Cornelia de Lange is a classic genetic condition that presents with failure to thrive and smallness in general. It is an autosomal dominant condition. Most are new mutations. Poor growth in IUGR, have limb abnormalities, and characteristic craniofacial features. So they have cynophorous and these arched eyebrows, long eyelashes, a short nose with anteverted nares, small head, and a long philtrum. And a lot of times that long, smooth philtrum makes you think that they have fetal alcohol syndrome, so there's some overlap with poor growth and long philtrum. But really they have Cornelia de Lange, and what you're looking for are those arched eyebrows and a little bit of that cynophorous crossing that midline. Mental retardation can be mild to profound. Reflux is common, and they can have congenital heart defects. So again, here's a little one with characteristic features. The limb defects can be anything from short fingers to missing digits to something called phocomelia. So you just get a little flipper at the very end, like this. You can also have syndactyly. And again, here's their own growth curve. So the normal is up here in the white. The gray is the normal growth curve for somebody with Cornelia de Lange. So if you're not plotting them on the right growth curve, you're going to think they're doing horribly whenever they're growing appropriately for their condition. Russell-Silver syndrome is also something that presents with smallness and poor growth. It's a sporadic condition, and about 10% are due to a uniparental disomy of chromosome number 7. So both number 7s are inherited from one parent, and you didn't get a copy from the other. So they have small height, small weight, but they have a normal head circumference. So Cornelia de Lange, everything's small. Russell-Silver, small height, weight, but normal head. Triangular shaped face, hemihypertrophy, cafe au lait spots, delayed bone age, and again, reflux can be a major issue with kids with Russell-Silver syndrome. Noonan syndrome is an autosomal dominant condition, also often due to a new mutation that presents with short stature. Characteristic facial features include wide-set eyes, low-set ears, and down-slanting palpebral fissures. So usually people with Down syndrome have up-slanting, down-slanting for Noonan's. If you draw a line straight across, you can see the palpebral fissures are now dropping below that line right here, and that the palpebral fissures are down-slanting, going outwards away from that line. Can have lymphedema prenatally. The old name for this was the male Turner syndrome. It has nothing to do with Turner syndrome, but they can also have lymphedema. They increase nuchal folds, but it can be male or female. The web neck, cryptorchidism in males, and congenital heart disease, most commonly a pulmonary valve dysplasia. Williams syndrome is due to a microdeletion on 7q11. So again, back to those fish studies. You'd have to fish for it to find it. They have short stature, and they do have their own growth charts. Have very characteristic facial features. They have a short nose, puffy eyelids, eyelids. If they have blue eyes, often you can see a stellate pattern, so it's like a starburst on the iris. And they have this full mouth with this patulous lower lip. They have mild to moderate mental retardation. They have a characteristic behavioral phenotype. They are loquacious. The only time I've ever seen loquacious used in a sentence has been in relation to a person with Williams syndrome. I've never seen it used in a literary way otherwise. Loquacious means you have a cocktail party personality, which means you talk a lot and don't say much. So they are very expressive. They will talk to you, but the content isn't what it's supposed to be. So often they'll score very high on their verbal skills, which is not a true reflection of their actual intellectual capacity. They also don't have a lot of boundaries, and so these are the 2-year-olds that don't have stranger danger. They just run over to the doctor and sit in their lap and talk to you for no apparent reason. They should be screaming on the other side of the room. I had one little girl that took up a conversation in Walmart with a biker with really long hair. Mom said she came around and looked at him, and this poor guy was just backing away. He realized how inappropriate this was, but the little girl did not. The characteristic cardiovascular defect is supravalvular aortic stenosis. If you look in the AAP guideline, there is a checklist in there that you can use to try to figure out if you should send testing or not. And you get enough points on this chart to send testing if you have supravalvular aortic stenosis. If you see that particular lesion, you should think about Williams syndrome. All right, question number 7. You're seeing a 6-year-old female new to the area for her preschool checkup. Her mom reports that she's always been small and was small for gestational age, but no reason has been found. She is a picky eater, but otherwise has no problems. Development is essentially on time. She's never been hospitalized nor had any surgeries. On your physical exam, her height and weight are less than the 10th percentile. She has a normal head circumference. She has a broad appearing forehead and several cafe au lait spots. Otherwise, there are no concerning findings. The most likely diagnosis is Down syndrome, fetal alcohol, hypochondroplasia, Russell-Silver, or XXX syndrome. You guys are just right on today. So, D, Russell-Silver syndrome. So, she's small, height and weight, normal head circumference. Normal development, not consistent with Downs or fetal alcohol. XXX does not actually have any specific problems except for tallness. So, you often don't pick that up unless you were looking for something else. So, women with a XXX often don't get diagnosed. Broad forehead, cafe au lait spots are typical in Russell-Silver syndrome. Hypochondroplasia would have frontal bossing and rhizomelic shortening. So just like it sounds like, it looks like a mild form of achondroplasia. It's hypochondroplasia. All right, bone marrow dysfunction. So people with this have a predisposition to cancer or isolated cell line abnormalities. So one of these conditions is ataxia telangiectasia. It's an autosomal recessive condition. And you get an early onset progressive cerebellar ataxia. You get telangiectasias that are most easily seen in the eye. They can have immunodeficiencies. They will have chromosomal instability. So when you send a karyotype, you get back really bizarre results. You not only get your 46 count, but you have all of these translocations and weird formations that are going on. So rather than just your regular chromosomes, you get these tetrads being formed. If you give them, and that's just on a normal karyotype, if you give them a little bit of ionizing radiation, you can just watch them fall apart. They have an increased risk of malignancies, particularly lymphoid malignancies, and just as a screening test, you can get an AFP, and they'll have an elevated AFP level. And these individuals usually die by their 20s. Bloom syndrome is also autosomal recessive. It's due to defects in the BLM gene. It's an codes for a DNA helicase, so the way that you can twist and untwist your DNA is abnormal. And you need this for maintenance of your genomic stability. So again, you're going to see funny things on your karyotype, and you're going to see increased sister chromatid exchanges. Poor growth and failure to thrive with prenatal onset. If your chromosomes can't divide the way that they're supposed to, you're not going to grow well. You have a telangiectatic erythema and a malar distribution, almost like a lupus pattern coming across. Bird-like facial features and primary hypogonadism. Fanconi anemia is an autosomal recessive condition with 13 genes that have been implicated, and it gives you increased chromosome breakage. So again, when you look at your chromosomes on a karyotype, they begin to fall apart, but rather than ionizing radiation, you have to do a special test called a DEB assay, which is a particular chemical that will begin to make your chromosomes break. It is the most common cause of bone marrow failure, and 75% will have some other kind of dysmorphology. So these kids aren't going to sneak up on you with their bone marrow failure. They're going to have areas of hyperpigmentation, abnormal thumbs and radial defects, so missing radius and thumb, short stature, hypogonadism, small head, renal anomalies, and developmental delays. So you can see here the club hands, and then here just the different areas of hyperpigmentation. So you should have a clue something else is going on before you get to your bone marrow problems. Black Van Diemen is an autosomal dominant condition due to defects in ribosomal protein S19. In 25% of cases, there are two other genes that have been implicated as well. It gives you a congenital erythroid aplasia, so just your red blood cell line. Gives you anemia, again, can give you thumb problems, small growth, heart failure, and craniofacial anomalies, including cleft lip. TAR, or thrombocytopenia absent radius syndrome. It's autosomal recessive. The slide says no gene has been found. They found a gene this year. I guarantee you that will not be on your test. So for the testing purposes, we don't know the cause, but people keep finding new things every day, which is why I love my job. Hemorrhage is a major medical problem, and intracranial is the most problematic. The risk is, however, reduced after 2 years of age. So if you can make it past 2, you'll do fine. They have upper extremity anomalies, anything from a radial ray absence to true phocomelia, but they always have thumbs of some kind. And so that's one of the major differentiating factors for all of these conditions. Do you have thumbs or do you not have thumbs? If you have a radial problem and you have no thumbs, you can't have TAR. You always have to have thumbs with TAR. And 46% will have some form of lower extremity anomaly as well. Bruton X-linked A-gamma globulinemia is an X-linked condition due to defects in the BTK gene. Important for pre-B cell maturation. You don't make plasma cells, and there are no antibodies that are made. You get recurrent infections, especially from encapsulated bacteria. You don't respond to antibiotics, and you get frequent sinopulmonary infections. You can also have skin problems like eczema, vitiligo, and alopecia. Chronic granulomatous disease has several different ways of being inherited. 2/3 are X-linked due to a cytochrome B subunit gene, so CYBB, and then 1/3 are autosomal recessive. Your phagocytes are unable to make an oxidative burst, and they give you recurrent life-threatening bacterial and fungal infections. So just like the A-gamma globulinemia, except even worse. Now you're going to get abscesses, you get the same sinopulmonary infections, but you can also end up with osteomyelitis, granulomas, so more severe types of infections. And the test that you do for this is the nitroblue terazolium test, or NBT test. Okay, X-linked SCID is the bubble boy disease. It's X-linked recessive due to mutations in IL-2RG. It gives you severe combined immunodeficiency, lack of T and natural killer cells, lymphocytes, and non-functional B lymphocytes. Gives you chronic infections, diarrhea, cough, congestion, fevers, pneumonia, and sepsis. Most of these people will die very early in infancy due to overwhelming sepsis. Different states have now incorporated this into newborn screening. So Wisconsin did it about 3 or 4 years ago, and where I'm from in Iowa, we're just now gearing up to start doing that as part of our newborn screening. So looking for SCID, and then that's also going to bring up all sorts of other things on the newborn screen, because again, it's a screening test. So if you live in a state where they're not doing it, just wait, it'll come to you. Okay. 3-year-old boy presents for evaluation of severe, persistent, and recurrent abscesses in the perianal area. His parents state that he had his first one at about 4 months of age. Parents are also concerned that he's had frequent otitis media, sinus infections, and 1 episode of osteomyelitis requiring hospitalization last month. Most likely diagnosis is Bruton's agammaglobulinemia, chronic granulomatous disease, DeGeorge, Wiskott-Aldrich, or SCID. So the answer is the chronic granulomatous disease. Remember that the agammaglobulinemia presents very similarly, but the chronic granulomatous disease is the one that has the osteomyelitis and much deeper-seated types of infections. Eczema and recurrent infections can also be seen in Wiskott-Aldrich, but they should also have platelet problems. And then DeGeorge can also have infections, but usually not these types of deep-seated types of infections. All right, connective tissue disorders. The Ehlers-Danlos syndromes. The majority are autosomal dominant. There are a few that are autosomal recessive. There are multiple genes that are involved, collagen genes being the majority, and then tenascin X. There are several different forms. Classic, hypermobile, and vascular are the 3 that you're going to run into the most commonly. The last 3 are going to present much earlier as an infant or as a toddler, and usually are much more rare. The classic type is like this guy who can take his skin and stretch it out for Ripley's Believe It or Not. He shouldn't be doing that because it's just going to keep stretching. The hypermobile form is the most common form. It's the people with the loosey-goosey joints. They have soft skin, but generally not as stretchy as this. The vascular one is the scary one where your vessels explode. That's the one everybody's afraid that you're going to have. So all of them have loose joints. So they all have joint hypermobility as a unifying feature. But then depending on the subtype depends on how fragile your small vessels are or large vessels, how badly your scar formation is, how soft and stretchy your skin is. Most of them still will have easy bruising. So the Beighton score, this is now time for tricks again. Total score of 9, you get 1 point for everything you can do. Pinkies that go past 90 degrees. Thumbs that can touch your forearms, elbows that go past 180 degrees, knees that go past 180 degrees, so you can see the lower leg going this way and the upper leg going that way, so your knees are bending back. This is my daughter Elena. She loves it whenever I display her EDS, and she's always standing like that. And I'm always telling her, don't do that. Okay, but you can see how then it increases the sway in your back. So these people end up with a lot of hip pain, back pain, simply because they're locking their knees back behind them. And then being able to put your palms flat on the floor. So a total of 9 points. You need at least 5 to have joint hypermobility. So everybody's allowed to have a couple of joints that are a little hypermobile, but to really have joint hypermobility, you need a score of 5. Everybody with all types of Ehlers-Danlos will pass the Beighton hypermobility score, but again, depending on how much stretchy skin or vascular problems you have, put you into different categories. Skeletal dysplasias. We talked a little bit about achondroplasia. Another one is cleidocranial dysostosis. This is a nice testing one because the people don't have clavicles, which you can see here. It's an autosomal dominant condition due to a RUNX2 gene mutation. They have abnormal skull bones with delayed closure of the anterior fontanelle. Again, absent or hypoplastic clavicles. Teeth abnormalities with late onset or just absent altogether, and short stature. If you don't have an X-ray and you're out practicing medicine somewhere, Clavicles are what keep your arms from being able to flip all the way around. So if you can take somebody and take their arms up and over, they don't have clavicles, or they're able to dislocate their shoulders. All right, sequences and associations. Everybody should be familiar with the Vactral association, vertebral anomalies, anal atresia, cardiac anomalies, TE fistula, esophageal atresia, renal anomalies, radial dysplasias, and limb anomalies. It's a non-random association of features. If you see one thing on this list, you should look for everything else. It's sporadic, and it's a clinical diagnosis. There's not a blood test for it. But you have to have no other explanation for the grouping of findings. So you have to have a normal karyotype. If you have a chromosomal problem, you don't have Vactral. You have your chromosomal problem that's giving you your birth defects. So you need at least 3 off of this list to have the clinical diagnosis of Vactral. And if it's associated with hydrocephalus, then that's a different condition altogether. And it's an autosomal dominant. So again, here's the radial aplasia. Here's some vertebral anomalies, and then there's not enough bowel gas down here, so there's some anal atresia going on. Klippel-Feil anomaly, people love to ask about. It's a defect in formation or segmentation of the cervical vertebrae. The 2 most common vertebrae affected is C2 and C3, and it's a fusion of 2 vertebrae to the entire C-spine, so it can be any variation on that theme, but the most common is C2, C3. When you look at somebody from the outside, they have a short neck, a low posterior hairline, decreased cervical motion, but fewer than half will have all 3 of those clinical signs. It can be part of another syndrome, or it can just be an isolated segmentation defect. Amniotic bands are a group of congenital anomalies caused by strands of the amnion that become attached to the fetus, wrap around something, and then you don't get vascular supply, so it doesn't get formed outside of where that band wrapped around. So it's a congenital amputation. I've seen babies too that inhale them, so you'll get really bizarre facial clefting, so not in a normal physiologic plane. They'll be going crossways across the face. So it can be amputation, webbing of fingers or toes, and then severe defects again can give you a cleft appearance to the body, to the head, spine. Pierre-Robin sequence is a form of micronathia or small chin, and then you have a secondary cleft palate because from the tongue displacement. So the chin is too small, the tongue is displaced up, the palatal shelves cannot come together. It gives you a U-shaped cleft as opposed to a V-shaped cleft. If you have a very small jaw, then your tongue is displaced backwards and you'll need a trach until you get bigger and you can do some jaw distraction. It's often seen as a component of Stickler syndrome, which can also have hearing loss and high myopia and retinal detachment. Remember, Pierre-Robin sequence is not a diagnosis in and of itself. It just describes what has happened. So it could be isolated, but it could be part of a variety of different genetic conditions. So just saying that somebody has Pierre-Robin doesn't tell you why or what the recurrence risk is. Potter sequence are features that are secondary from oligohydramnios and usually from classically due to renal agenesis. So if your kidneys don't form, you don't make urine. If you don't make urine, you don't make amniotic fluid. If you don't make amniotic fluid, you can't grow your lungs, so you end up with pulmonary hypoplasia. If you don't have amniotic fluid, your extremities can't move appropriately, and so you end up with all sorts of bizarre limb positioning problems. And the face becomes flattened. You have a recessed chin. Ears can be very low set, and again, the pulmonary hypoplasia. And for that reason, most of these children don't survive past the early neonatal period. Pena-Choquer is fetal akinesia syndrome. It's an autosomal recessive condition due to mutation in RAPSN gene. Gives you intrauterine growth retardation, arthrogryposis, which is just contractures of all of your limbs. Again, pulmonary hypoplasia, if you can't move enough and that chest wall can't move air or move the amniotic fluid in and out, then the lungs won't grow. expressionless face, neurogenic muscle atrophy. They can have CNS anomalies. And then they can also have polyhydramnios because they're not able to suck, swallow, and move the air in and out of their lungs appropriately. Prune belly syndrome has an uncertain etiology, but you do have deficient abdominal musculature, cryptorchidism, and urinary tract abnormalities. Can be associated with other anomalies, and it's more common in males. All right, you are examining a newborn infant and notice that her head always turns to the right and resists movement to the left. You also note that her back does not appear normal. On physical exam, her hairline appears low posteriorly. Her right scapula appears to be higher on the left. And you note that the spine does not appear to be perfectly straight, suggesting congenital scoliosis. You obtain an AP radiograph of the cervical spine, which shows multi-level segmentation anomalies in the mid to lower cervical spine. Condition that is most consistent with these findings are cleidocranial dysostosis, Klippel-Feil, Noonan's, Pinot-Choquer, or Turner syndrome. You guys don't need my lectures at all. Look at this. You guys are great. Okay, so this is Klippel-Feil. Cleidocranial dysostosis would be missing clavicles. Noonan and Turner syndrome can both have low posterior hairlines but don't have spine abnormalities. And Pinot-Choquer has congenital arthrogryposis of multiple joints in the immobile face. All right, moving on. Metabolic and hormonal bone diseases. So McCune-Albright is a gain-of-function mutation in the GNAS1 gene, and it's a somatic mosaic. So there was a mutation that occurred while the embryo was forming, and only certain cells have the mutation. It gives you a polyostotic fibrous dysplasia. It will give you cafe au lait spots. The cafe au lait spots are typically the coast of Maine cafe au lait spots, which is in opposition to the coast of California. If you've been to Maine and California, this will begin to make sense. Maine has lots of islands. So coast of Maine looks like a sponge painting to me. You can't really tell where the true boundaries really are. There's lots of inlets and outlets. The coast of California tends to be much smoother, and you can draw a much nicer line just around the edge and borders. They have autonomous endocrine hyperfunction. Precocious puberty is the most common feature in females. They can also have adrenal adenomas and hypothyroidism. Another disorder that is due to problems in the GNAS1 gene is pseudohypoparathyroidism. It's also called Albright hereditary osteodystrophy. So McCune-Albright or Albright hereditary osteodystrophy, two different diseases named by the same guy to keep us all confused. Okay? But this is pseudohypoparathyroidism due to an imprinting defect in GNAS1. And it gives you resistance to parathyroid hormone. There are three forms, 1A, 1B, and 1C. They have elevated PTH, low calcium, and elevated phosphorus. These people have short stature and obesity. They have abnormal teeth and short metacarpals, particularly the fourth and fifth metacarpal. So you can see this hand that there's this drop off here. So when they make a fist, it just sort of drops off. Hypophosphatasia is due to a mutation in the alkaline phosphatase gene, or ALPL gene. It is autosomal recessive. Gives you defects in bone mineralization and abnormal protein production of alkaline phosphatase. Has various onset, all the way from a congenital, lethal type of disease to an adult onset where you have bad teeth. Major features are rickets or fractures and bone changes, failure to thrive in infancy, premature loss of teeth, and you can have premature closures of your skull sutures. When you look at labs, you'll have a low alkaline phosphatase level. So you have a rickets-like picture, but yet your alk phos hasn't gone up appropriately. High to normal calcium and normal phosphorus, and your vitamin D and PTH are all normal. Familial hypophosphatemic rickets. Two forms, autosomal dominant and X-linked. In the X-linked version, it's more severe in males, and it's the PHEX gene, P-H-E-X. Pattern of labs include a low to normal calcium, a high alkaline phosphatase as opposed to a low, and a low phosphorus. And here you can see the person with the rachitic rosary. Hopefully you don't get people that bad, and here's the severe bowing. Again, frontal bossing, short stature, and the bowing of the limbs. All right, so back to clinic. 7-day-old baby, well child checkup. Baby had a birth weight of 3,000 grams and now weighs 3,100 grams and is 48.3 centimeters long. Mother reports that she is breastfeeding and the baby seems to be feeding well. He is her first child. Mom tells you that she takes thyroid hormone for an underactive thyroid and is needed to take calcium and vitamin D since she was a small child to, quote, keep her calcium up. You look at her more closely and realize that she is plump and quite short, perhaps 4'10", has a round face and short stubby fingers. She says that her mother also had short stature and similar problems. She has one brother who had similar problems and a sister who is 5'6" and does not have a problem with her calcium. Of the following, this baby and his mother most likely have McCune-Albright, multiple endocrine autoimmune syndrome, pseudohypoparathyroidism, Noonan syndrome, or vitamin D resistance. So what we're looking for here is the pseudohypoparathyroidism. So autosomal dominant disorder, the body doesn't respond to the parathyroid and other hormone effects mediated through the G protein, the GNAS1. So you tend to be short and stocky, short fourth metacarpals and metatarsals, and relatively slow mentation, and you could actually have mild mental retardation. McCune-Albright has same gene, but gain of function, so you have the polyostotic fibrous dysplasia, the cafe au lait spots, and sexual premature puberty. Noonan syndrome doesn't have problems with hormone or calcium problems, and vitamin D resistant rickets is not associated with the hypothyroidism. All right, single organ dysfunction, polycystic kidneys can be recessive or dominant. Dominant is the most common in 90% of cases, so PKD1 and PKD2. And then the autosomal recessive can show up prenatally and in the infantile setting and is due to mutations in PKHD1. Both have growth of multiple cysts in the kidneys, and usually the ones that are recessive are much larger and take over the kidney much earlier, hence the infantile onset. The dominant form is also associated with liver cysts, pancreatic cysts, aneurysms, and diverticulosis. Autosomal recessive has risk for renal failure and all of its complications and may also have pulmonary hypoplasia associated with it. Nephrogenic DI are X-linked recessive and dominant forms. AVPR2 is the X-linked form, and AQPT-P2 can have recessive and dominant forms associated with it. So the features of nephrogenic DI, polyuria, polydipsia, and failure to thrive. Long QT syndromes are autosomal dominant, and there's multiple genes that are associated with long QT syndrome. There is a prolonged QT interval that makes you susceptible to arrhythmias and sudden death. Cartaginer syndrome is autosomal recessive and again due to defects in multiple genes. Gives you a primary ciliary dyskinesia and situs inversus. Clinical features include recurrent respiratory infections, bronchiectasis, infertility, and dextrocardia. The thing that we can no longer do is make the mistake of correcting the dextrocardia on the films. When you went to put up your film and you went, that's not right, and you turned it around and corrected it. Now that most of us do things online, you can't do that. So you actually find your dextrocardia better now because we can't radiographically correct it. All right, a 2-year-old girl presents with a history of chronic upper and lower respiratory tract infections. Her weight is at the 25th percentile, height at the 10th percentile. Temperature is 91.8 or 36.8. Pulse ox is 96% on room air. On physical exam, she coughs intermittently and has mild clubbing. On nasal exam, you note purulent rhinorrhea and nasal polyps. X-ray shows dextrocardia. Most likely diagnosis is cystic fibrosis, HIV infection, primary ciliary dyskinesia or Cartageners, chronic granulomatous disease, or X-linked skid. So the key here is the dextrocardia. It could very well be CF, and that's usually the first thing you think about in a child with failure to thrive, clubbing, pulmonary functions not going well. But the fact that she also has the dextrocardia now puts you into Cartageners. And then again, if you've had HIV or some other primary immunodeficiency, you would expect more than just what you're seeing. Skin and teeth problems. Sturge-Weber is isolated, sporadic. We don't know the actual cause of it. You get a hemangioma in the trigeminal nerve distribution, a big head macrocephaly. You can get angioma of the meninges, and you can also develop glaucoma depending on how extensive that hemangioma is. Ectodermal dysplasias can occur in X-linked, recessive, and dominant forms, so there are multiple genes that are involved. There are more than 190 disorders that are described based on clinical features. So it may be just your straight up ectodermal dysplasia, but it can also occur as part of other conditions as well. So your ectoderm should be abnormal. Abnormal hair, abnormal teeth, abnormal ability to sweat, and it may not be just a complete inability, but not complete. So a hypohidrosis. So you can't get all the way there, or different. You may have different patches that can sweat. And then abnormal nails. And again, these peg-like shaped teeth. And a lot of people have hypodontia as well. Tuberous sclerosis can present with skin findings. It is an autosomal dominant disorder affecting about 1 in 6,000 people. Two genes that are that cause the disease, TSC1 and TSC2. Tuberous sclerosis is actually tuberous sclerosis complex, because if you try to abbreviate it TS, in the International Abbreviation Catalog, TS is actually Tourette syndrome, but it can also be Turner syndrome. And so they chose to call it tuberous sclerosis complex, or TSC, so that way everybody isn't as confused. The genes are on chromosomes 9 and 16. There's marked variability within and between families. And the classic findings for skin findings in tuberous sclerosis are these ash leaf or hypopigmented macules. The hypopigmented macules don't actually have to look like ash leaves, but that was their classic description. Sjogren patch is this sort of roughened area here. It's hard to take a good picture of it because it's better felt than seen. You rub your hand over it and it's a thickened patch of skin. You get facial angiomas. Adults often think they just have bad acne, and it's not. Ungual and gingival fibromas often present in infancy with infantile spasms. Cardiac rhabdomyomas are usually picked up prenatally, and they can be problematic and be obstructive and send the person into cardiac heart failure or congestive heart failure, but more likely they have no problem at all and they regress over time. So if you're seeing somebody who's 6 or 7 years old and you get an echo, you may not see a feature that may have gone away. So cardiac rhabdomyomas typically are seen prenatally and in infancy. And then you can also have renal tumors such as angiomyolipomas. NF1 is common. It is about 1 in 3,000 people have it. There is an AAP guideline for it. There are clinical criteria including café au lait spots, axillary inguinal freckling, neurofibromas, Lisch nodules, optic gliomas, skeletal abnormalities. About half of the people will have learning disabilities or ADHD. It's not one of the diagnostic features, but is very common in that population. Out of the list, you need 2 clinical features. If you have a family history, you only need 1 clinical feature. It's an autosomal dominant condition due to mutations in the NF1 gene. About half are new mutations. The other half are inherited from a family member. It's a tumor suppressor gene, so it regulates RAS, and it's involved in control of mitosis and cell division. So the people with NF, their cafe au lait spots are these coast of California, nice smooth ones as opposed to those coast of Maine. And you can see here 1, 2, 3, 4, 5, 6, just on the back. And if you flip her over, you'll probably find a bunch more. Doesn't matter if you have 6 or 600, you have NF. It doesn't tell you how bad or how severe the disease is going to be. Freckling where the sun doesn't shine. You should have sun freckles on the outside and not on the inside where it is been shaded. So looking in somebody's armpit or groin. Neurofibromas can come up on the skin or under the skin. So they may look just like these little balls here, but they may just sort of undermine and you may be able to feel them better than see them. Lish nodules you see with the slit lamp, so we send them to ophthalmology for that. Right, a 4-month-old boy presents with complaints of colic. Mother reports that 4 to 5 times a day his painful episodes so severe he repeatedly flexes his arms and legs at once. He then cries after the episodes. Family history is notable for his mother having a history of seizures starting at 16 years of age. On physical exam, his growth is normal. He has 3 ash leaf macules on his trunk. Presentation is most consistent with gastric reflux, hypothyroidism, tuberous sclerosis, Down syndrome, or NF1. Excellent. So the answer is tuberous sclerosis. And so the episodes could be mistaken for reflux, but what that's really describing is an infantile spasm. And that's what's seen with tuberous sclerosis. Hypopigmented macules go with TSC. Hyperpigmented macules or cafe au lait spots go with NF. And hypothyroidism would cause developmental delays, but really shouldn't see any of the skin findings. All right, disorders with AAP guidelines. Downs, Williams, Turner's, Marfan's, NF1, ACON, Fragile X, Prader-Willi. Sickle cell, fetal alcohol, spina bifida, and the evaluation of adopted children. Usually the first paragraphs in all your AAP guidelines, has a nice, simple overview. And they often take test questions just from that, from those brief introductions. The other nice part about the guidelines is just in day-to-day practice, they give you flow diagrams of what you should be doing when people come in for their well child exams. The oncogenetic syndrome, if you've got more than one birth defect, developmental delay, mental retardation, physical features that differ from the rest of the family, growth problems, family history of genetic disease, certain health problems just run in the family, and clues that it could be a genetic syndrome. Your head is too big or too small, you have a heart defect, you're too short or too tall, you have birthmarks or abnormal skin findings, you have failure to thrive despite having good nutrition, limb or spine or back anomalies, and any combination really then starts to up the ante. And we're done right on time. Yay.